A 22-year-old man presents in the emergency department gasping for air. His oxygen saturation is plummeting, and his lungs are failing, but there is no fluid, no infection, and no visible obstruction. To understand why he is suffocating, we have to look at the physics of the red cell. Sickle cell disease is governed by an oxygen-dependent physical state change. A normal red blood cell is a flexible biconcave disc designed to squeeze through capillaries a fraction of its own width. Sickled cells lose that elasticity. They become rigid, microscopic emboli that jam within the microvasculature. Surviving a sickle cell crisis depends entirely on pinpointing exactly where in the body these cells undergo this physical transformation and how that specific location compromises the patient's systemic oxygen supply. The pathology begins with a base pair swap in the DNA sequence. Adenine is replaced by thymine. This alters the protein. On the sixth position of the beta-globin chain, glutamic acid is swapped for hydrophobic valine, creating a highly reactive, sticky patch on the hemoglobin molecule. As long as the blood remains fully oxygenated, the molecule behaves normally. But as the cell travels into the capillary beds and oxygen tension drops, this structural mutation forces the abnormal hemoglobin, HbS, to crystallize. Free-floating hemoglobin molecules rapidly snap together, polymerizing into thick, rigid fibers made of 7 intertwined double strands. This internal crystalline growth physically distorts the cell's lipid bilayer from the inside out. The flexible disc is stretched into a fragile, rigid sickle shape that is almost guaranteed to become trapped in narrow vessels. When these rigid cells lodge in the capillary beds of long bones and joints, they create a severe traffic jam, a standard Vaso-Occlusive crisis. This pelvic MRI shows the direct physical consequence. In the hip joints, we see dark, irregular lesions in the femoral head. These areas represent avascular necrosis. The trapped cells have blocked the bone's microvasculature, starving surrounding tissue of oxygen and causing irreversible cell death. We see the structural fallout on this radiograph of the upper femurs. The bone density is highly irregular, showing extensive degradation as the skeleton physically breaks down from repeated local infarctions. The standard medical protocol for localized ischemia is aggressive hydration to improve blood flow and heavy opiate analgesia to manage the excruciating bone pain. While a vaso-occlusive crisis causes profound local tissue destruction, the ischemia remains isolated to the limb. It does not immediately threaten the patient's global respiratory system. A patient presenting with severe chest or back pain is often presumed to be having another routine bone crisis. But behind that familiar symptom, a sudden drop in blood oxygen and a new pulmonary infiltrate signal a much more immediate danger. Blocking a femur capillary is mechanically different than blocking pulmonary ones. In acute chest syndrome, sickled cells occlude lung microvasculature, dropping local oxygen. This hypoxia triggers explosive sickling in adjacent healthy cells. The blockage rapidly spreads outward in a runaway, suffocating feed-forward loop. The diagnostic criteria are strict. Severe pain alone points to a vaso-occlusive crisis. Pain accompanied by hypoxemia and a new pulmonary infiltrate defines acute chest syndrome. Treating this cascading pulmonary failure with only intravenous fluids and opiates is a fatal error. Hydration and pain control do nothing to interrupt the physical polymerization loop that is rapidly suffocating the patient. To save a patient in acute chest syndrome or facing a stroke, the medical team must mechanically break the hypoxic loop. Simply giving a standard blood transfusion is inadequate and often dangerous. Packing more red blood cells into the vessels increases overall blood viscosity, which worsens the microvascular traffic jam. The required intervention is an automated exchange transfusion. The pathogenic, polymerized cells must be physically extracted from the patient's circulation while being simultaneously replaced with healthy donor blood. This graph illustrates the physiological target. The medical team continues the exchange until the patient's fraction of sickled hemoglobin is driven safely below 30%. With the rigid fibers removed, the highly flexible donor erythrocytes can easily navigate the narrow, branching pulmonary capillaries, rapidly restoring systemic gas exchange. Mastering the management of this disease requires looking past the symptom of pain. It requires directly treating the mechanical state change driving the ischemia.